Welcome back to part 2 of SIADH versus DI. Let's continue where we left off. Let's look at the complete opposite now, and that's DI, or diabetes insipidus. Diabetes insipidus is a condition in which the hypothalamus produces not enough antidiuretic hormone, so the pituitary gland has no ADH to release. Remember, antidiuretic means we are not diuresing, aka we are holding in water. So if we don't have enough ADH being released during diabetes insipidus, the kidneys cannot conserve water in the body. And now we are losing more water than is desired, which upsets the body's balance of electrolytes. You can remember this by thinking DI for dry inside. You are losing fluids and becoming like SpongeBob in that one episode where he's begging for water. Now, why does this happen? Why would someone be diagnosed with DI? Common situations where the body releases not enough ADH include damage to the hypothalamus or pituitary gland during surgery or radiation, disorders of the brain, just like in SIADH, NCLEX tip, brain injury caused by increased intracranial pressure suppresses the pituitary gland function. Other conditions include lung disease, cancer, TB, pneumonia, and chronic infections. Symptoms of DI revolve all around that dried out little SpongeBob sitting on the toilet. If the body is peeing out so much fluid, urine output will be increased, which is what we call polyuria. If we're peeing out tons of fluid, then we have extremely diluted urine. Think about when you drink a ton of water and you pee that out. Your pee is clear, right? A little tip for the NCLEX, this is what we call low urine specific gravity. It is so diluted, it's going to be less than 1.005. Now, if we are losing fluids, we are dehydrating our insides, right? We are dry inside, which means common labs would show hyperosmolality and hypernatremia. The patient will have dry skin and dry mucous membranes with decreased blood pressure. And of course, they're very thirsty like SpongeBob in that episode. So, you've been diagnosed with DI. Now, how do you treat it? The goal is to increase fluid retention and improve tonicity homeostasis. If the body is not naturally producing or releasing enough ADH, we need to give the patient a man-made form of ADH, right? These drugs end in pressin, like desmopressin and vasopressin. Think these drugs will press or contract the renal ducts to decrease urine output and increase fluid in the body to balance water and sodium. Another way to increase fluids in the body: tell the patient to drink water. If oral intake is inadequate, administer dextrose and normal saline slowly to avoid fluid volume overload or hyperglycemia. And of course, we have the same nursing considerations for DI as we do for SIADH. Last little tidbit to wrap up SIADH and DI, in both conditions we're messing with our sodium to water ratio, right? In SIADH, the patient is soaked inside, which dilutes many substances in the blood such as sodium. In DI, the patient is dry inside, which causes more sodium than total body water. For the NCLEX, remember that the brain is particularly sensitive to changes in sodium level, so we monitor for neurologic changes to prevent seizures and death. Early signs: headache, confusion, lethargy, and hyponatremia. And late signs: if sodium levels fall quickly, the patient will experience muscle twitching and seizures. If untreated, we'll see unresponsiveness, coma, or death. And that wraps up our lecture on SIADH and DI. I see you pausing this video, taking notes left and right. You don't need to do that. Everything you heard is available in study sheet form on my Etsy shop. Check it out.
I love it. That's great. That's
Woo! Yeah, like, subscribe, everything.